This conference will now be recorded.
Good morning all. Am I audible?
Yes, ma'am.
Yeah, please don't give your attendance in the chat box, please. So today's topic is anti-glaucoma drugs. You know how glaucoma occurs, right? So what is glaucoma? Raising the intraocular pressure, it consists of a triad, right? I think somebody covered about this topic, so I'll just tell you what are anti-glaucoma drugs. So why do you want to start anti-glaucoma drugs, and what is the goal of giving anti-glaucoma drugs? What we have to achieve by giving anti-glaucoma drugs? It is mainly to preserve the vision. We can't do anything with the vision which is lost already, but at least we can delay or we can stop the progression of the vision loss or optic nerve damage further by giving anti-glaucoma drugs. Okay, it also should delay the glaucoma changes in the optic disc, okay, and restore the vision to the patient. Okay, so how these anti-glaucoma drugs act? There are various ways. One is reducing aqueous production itself from the ciliary body. So ciliary body produces aqueous, right? So it will reduce the production of the aqueous from the ciliary body by promoting aqueous humor outflow through the trabecular meshwork. This is one of the drainage methods of aqueous humor. So it increases the drainage of the aqueous humor through trabecular meshwork. And the second way of aqueous humor drainage is the uveoscleral pathway. So also it increases the outflow of aqueous humor through the uveoscleral pathway. So there are two ways, either to reduce the production or to increase the drainage of the aqueous humor. These are the two ways how the anti-glaucoma drugs act. So anti-glaucoma drugs can be topical or systemic. So coming to topical anti-glaucoma drugs, there is a classification. These are beta blockers, adrenergic agonists, prostaglandin analogs, cholinergic agents, and carbonic anhydrase inhibitors. So beta blockers, timolol is the most commonly used drug, which is the first drug to start with open angle glaucomas. So next one is cartiolol, betoxolol, levobunolol, and metoprolol. So adrenergic agonists, epinephrine, dipivefrin, brimonidine, and apraclonidine. Most commonly used drug is the brimonidine in adrenergic agonists. Next, coming to prostaglandin analogs, latanoprost, bimatoprost, and uniprostone. This is the latest drug. Uniprostone is the latest drug, but most commonly used is latanoprost. So cholinergic agents, pilocarpine, carbachol, dimethicurium bromide, and ecothiopate iodine. The most commonly used is pilocarpine. So carbonic anhydrase inhibitors, dorzolamide and brinzolamide, both are used, but most commonly used is the dorzolamide. So these are all the topical drugs available. Now coming to systemic inhibitors, like topical drugs, like topical drugs, in systemic also there are carbonic anhydrase inhibitors. The same thing, acetazolamide is present both in oral form and in the topical drops form. This is the only drug which is present in anti-glaucoma drugs in both as oral and topical. And the next carbonic anhydrase inhibitor which can be given orally is midazolamide, but the most commonly used is acetazolamide. Next, osmotic agents are present which are given through systemic route: glycerin, mannitol, and urea. Glycerin is a thick gel which is present in a bottle and it is given in the form of a syrup. Thick gel, like your sanitizer, it will be just like that only. And mannitol is usually given IV injections. Okay, or sorry, IV saline drips. Okay, so these are the osmotic agents we use. Now coming to beta blockers, which is the first type of classification. It is the first drug of choice in open angle glaucomas. So it causes reduction in the aqueous secretion. I told you that there are two ways, either production reduction or a drainage, increase in the drainage. So it reduces the production of the aqueous from the ciliary body. It has effect on beta 2 receptors. So beta blockers, I told you, it is a beta blocker. It has specific effect on beta 2 receptors, which leads to decrease in the aqueous production, which further leads to decrease in the IOP. See, there are various drugs. Okay, how it acts? Sorry. So it antagonizes the effect of catecholamines and further reduces the production of the aqueous humor. So it reduces aqueous formation by 24 to 48%. Beta blockers are ineffective during sleep time. Okay, so ineffective during sleep time. When the patient is awake only, it produces action. So coming to adverse effects on central nervous system, amnesia, depression, confusion, headache, impotency, insomnia, migraine, and myasthenia gravis. These are all very rare types of adverse effects. Very rarely we will see. The most acceptable drug by the patient will be the timolol always, which is a beta blocker. Next, gastrointestinal diarrhea and nausea if there is some systemic absorption. Pulmonary bronchoconstriction, bronchospasm, asthma, and dyspnea. So this drug, any patient, if you are going to prescribe timolol, first you have to take history of any bronchial asthma or COPD. Patients with bronchial asthma and COPD, beta blockers, that is the timolol, is contraindicated. You should never give in a patient with bronchial asthma. The most common the most important contraindication for beta blockers is asthma. So cardiovascular, bradycardia, conduction arrhythmias, hypotension, Raynaud's phenomenon, and fluid division. This is all very vast. It's not required. So ocular side effects. These are all systemic side effects. Previous slide. These are all ocular side effects. Allergic blepharoconjunctivitis. Dry eye can occur. Corneal anesthesia can occur. Macular edema, especially in aphyxis because of absorption. Macular hemorrhage or retinal detachment, uveitis, and cataract progression. So beta blockers, common indication is the open angle glaucoma. It can also be used along with other drugs in angle closure glaucoma, secondary glaucomas, and glaucoma in children. But the most common indication is open angle glaucoma. In open angle glaucoma, if the patient is quite acceptable with timolol, timolol will be sufficient. Single drug is sufficient. But if still the patient's IOP is not reducing, then you have to give combination of drugs. But in angle closure glaucoma, only timolol will never work. We have to give along with other drugs. So what are the most common contraindications are? Bronchial asthma, the first one. So history of bronchial asthma or COPD is very important. If any severe heart block is there, it should not be given. Overt cardiac failure in children and infants, all these people and patients with severe COPD, you are not supposed to give beta blockers, that is timolol. Now coming to the second group, adrenergic agonist, it is mode of action is, it also reduces the formation of aqueous humor. And along with that, it also increases the uveoscleral outflow. Okay, so these two are the main actions. In adrenergic agonists, both actions will be there. The first one is decrease of aqueous humor formation from the ciliary body, and the second one is that it will cause increase in the uveoscleral outflow. Just 1 second. Sorry for the inconvenience. So it also reduces, please don't give your attendance in the chat box. So it causes both decrease in aqueous humor formation and also causes increase in the uveoscleral outflow. So various adrenergic agonists are, it can be both alpha and beta agonists or can be alpha 2 selective agonists. Okay, so alpha and beta, epinephrine, dipivifrine and phenylephrine. Selective is brimonidine and epaclonidine. The most commonly used is the brimonidine. So side effects, stinging sensation, broache, conjunctival hyperemia, there will be congestion of the conjunctiva, adenochrome deposits, allergic lid reactions, they can be itching of the lids, macular edema, blepharoconjunctivitis, systemic hypertension and arrhythmias. And the contraindications is for cardiac diseases. So in cardiac diseases, you are not supposed to give adrenergic agonists. Severe hypertension and thyrotoxicosis. These are the contraindications for adrenergic agonists. So what are the side effects? There is systemic and ocular side effects. The patient will have allergy, contact dermatitis, blurred vision, stinging and burning sensation. Sometimes follicular conjunctivitis, photophobia. Because the patient will have photophobia. Patients who underwent LASIK and having already glare, we are not supposed to give adrenergic agonists in those people also. Okay, so coming to systemic, dry mouth, fatigue, drowsiness, headache, bradycardia and hypothermia in neonates. Okay, so these are the systemic side effects. Next, coming to the third group of drugs, the first one is the cholinergic drug. So mechanism of action, it causes contraction of the iris sphincter, that is constriction of the pupil leading to miosis. And the second one is it facilitates aqueous outflow through the trabecular meshwork. So drainage of the aqueous outflow to the trabecular meshwork. And the third one is it also causes contraction of the ciliary muscle circular fibers and causes accommodation. Because there is meiosis in accommodation, one of the component is meiosis, right? So it also causes accommodation, it causes meiosis, and the third one is it increases. So what happens when meiosis occurs? So what happens when pupil constricts? So when pupil constricts, there will be opening of the trabecular meshwork. Okay, so there will be opening because the circular fibers of the iris, they will expand and release the holes in the trabecular meshwork. Okay, so then what happens? It accommodates flow of aqueous humor through the trabecular meshwork. Okay, so this is how it acts. So when there is meiosis, there will be opening of the trabecular meshwork, which leads to, I'll show you the picture, just one second. So you can see here, this is the iris, right? This is iris, and here you can see the trabecular outflow here, right? So when the pupil constricts, iris, when the pupil constricts, there will be extension or what we have to say, expansion of the muscles of the iris. So when this happens, here you can see the trabecular meshwork opens. This is all the trabecular meshwork. This opens, and there will be flow of the aqueous humor, drainage of the aqueous humor through the trabecular meshwork. This is how it acts. Okay, and also it also causes accommodation. So classification of cholinergic agonists, they can be directly acting or indirectly acting. So indirectly acting, they act on the cholinesterase inhibitors. So directly acting, activate cholinergic receptors directly at the neuroeffector junctions of the iris sphincter muscle and the ciliary body and causes constriction of the pupil. Sorry. Coming to indirect action, exerts their cholinergic effects primarily by inhibiting the cholinesterase. So it inhibits the cholinesterase, it acts as an inhibitor of the cholinesterase, thereby making increased amounts of acetylcholine available, which leads to contraction. So cholinergic drugs indications, acute and chronic narrow angle glaucoma. The most common drug we use in a narrow angle glaucoma or angle closure glaucoma is pilocarpine, which is a cholinergic drug. Sometimes we use in open angle glaucoma and prophylaxis in primary angle closure glaucoma. That is until we do peripheral iridotomy. Until we do peripheral iridotomy and create another channel for the aqueous to drain, we will give pilocarpine to constrict the pupil. Okay, but if the patient is having some work and he doesn't want to undergo peripheral iridotomy right now, we will keep him on pilocarpine, and once the patient comes, we'll give peripheral iridotomy and we'll stop this thing, pilocarpine. So ocular side effects, as usual with pilocarpine, what happens? There will be accommodative spasm, constriction of the pupil will be there. Because of the drug reaction, there will be follicular conjunctivitis. Sometimes pupillary block will be there with secondary angle closure glaucoma. Because too much of constriction, the aqueous which is going to pass through the pupillary area, that will not occur, and further there will be angle closure glaucoma. Some of the aqueous humor will drain through the pupil, right? So the aqueous humor which is draining to the pupil, because of very small pupil, it will not drain. Why? Why? Because the aqueous is a thick gel-like thing, so it will not drain. Okay, so further that will lead to angle closure glaucoma. That is the pupillary block glaucoma. Band keratopathy, allergic blood flow conjunctivitis were the most common things. Coming to systemic side effects, because there is constriction and accommodation, there will be headache, broache, marked salivation will be there, nausea will be there, vomiting, bronchospasm, bradycardia, all of these are systemic side effects. There is no need for you to remember all these things, at least 4 or 5 you can remember. Now the contraindications for this cholinergic drugs are, if any cataract is there. Why if cataract is there we can't give cholinergic drugs? Because if the pupil constricts more, the light rays which are passing and reaching the retina will reduce, right? So the patient will have more defective vision when compared to normal people. If there is cataract, we should not give cholinergic drugs. Patients younger than 40 years of age, why? Accommodation comes into action. If the patient is less than 40 years of age, then there will be decrease in the near vision. So there will be blurred near vision because the pupil constricts and more accommodation comes into action, which is more than required. Okay, so neovascular and uveitic glaucoma, history of any retinal detachment, any history of asthma, then also we are not supposed to give cholinergic drugs. So in asthma patients, we should not give beta blockers and cholinergic drugs. In high myopia and hypertensive patients with known hypersensitivity. And coming to the next group of anti-glaucoma drugs, prostaglandin analogs, right? Prostaglandin analogs. So originally discovered in the eye as mediators of the ocular inflammatory response, it is a prodrug converted to active compound by corneal esterases. Mechanism of action is very important, increases the uveoscleral outflow. How it increases the uveoscleral outflow? It stimulates collagenase and metalloproteinases, also degrades the extracellular matrix in the ciliary muscle, which leads to hydraulic resistance, further causes uveoscleral outflow. So you can just write what is the mechanism of action. It increases the uveoscleral outflow. So indications, this can be given in any type of glaucomas usually. Okay, so it can be given in primary open angle glaucoma, normal tension glaucoma, chronic closure glaucoma, pigment dispersion syndromes or glaucomas, and exfoliative glaucomas. Any type of glaucomas usually you can give prostaglandins. So contraindications, if the patient is allergic to prostaglandins or the patient is pregnant or nursing mother. In children, only contraindication where you can't give prostaglandin is uveitic glaucoma, because it increases the uveitis inflammation. Because it has inflammatory response, it increases the uveitis. So in patients with uveitic glaucoma, we can't give prostaglandin analogs. So in the immediate post-operative period also we can't give prostaglandins. Why? Because it increases the inflammation. If you manipulate within the eyeball, anyway there will be mild iritis. If you give prostaglandins, the iritis will increase and further the patient will have more uveitis. So immediate post-operative period we can't give prostaglandins. So patients with herpes simplex keratitis healed or active also we can't give prostaglandins. Coming to ocular side effects, causes more damage to iris and cornea. This is the most important thing we have to remember, that prostaglandins usually, that's the reason if you start prostaglandins to any patient, we are supposed to ask the patient within next 3 days, so that if any damage to the cornea or any reaction in the cornea or iris, we have to see. So cornea punctate erosions, corneal pseudodendrites and recurrent herpes simplex keratitis, it causes conjunctiva. The patient, most of the patients with prostaglandins will come on the second day that the eye has become red. Okay, so there will be hyperemia. This is the most common complication we see or the side effect we see with prostaglandin. So you have to say if the patient comes to you with hyperemia, we have to think that the patient is having some allergic reaction to prostaglandins and we have to stop prostaglandins. Or if the patient is okay with that, you can continue prostaglandins. So eyelashes, lengthening of the eyelashes will be there, thickening of the eyelashes will be there, and pigmentation, hyperpigmentation of the margins of the eyelashes will be there. You can see here. Sorry. In this picture, you can see there is thickening of the eyelashes, right? Here you can see lengthening of the eyelashes. There is increase in the length of the eyelashes. Here you can see initially it is small, but later there is lengthening of the eyelashes and also thickening of the eyelashes is there when compared to here. Okay, so there will be lengthening of the eyelashes and thickening and sometimes hyperpigmentation of the eyelashes. In iris, you can see irreversible hyperpigmentation. Here you can see there will be irreversible hyperpigmentation. In this picture, you can see this is hyperpigmentation. Normal is this. There will be irreversible hyperpigmentation. So periorbital skin hyperpigmentation also will be there. So this is which is cosmetically not acceptable by many people. And sometimes you can see allergy and anterior uveitis. So systemic side effects, occasional headache, skin rash like which is present on the eyelids and upper respiratory tract infection. So what are the advantages of prostaglandins? Usually any glaucoma drug we have to give either twice a day or thrice a day. If it is oral, sometimes we have to give thrice a day. It is if topical, usually it is twice a day. Okay, but the advantage with the prostaglandin is it can be given only once daily. Okay, it's a single dosage drug. So lack of cardiopulmonary side effects. If the patient is cardiac patient, you can happily give latanoprost or travoprost. So it can be given with other anti-glaucoma medications. So if you already have given patient timolol, then we can give along with that we can give even prostaglandin analog. Okay, so its advantage is very important in your viva. What are the advantages of prostaglandin analogs? Once daily usage, lack of cardiopulmonary side effects, and it can be given along with other anti-glaucoma drugs. Now coming to the next group, carbonic anhydrase inhibitors. It inhibits enzyme carbonic anhydrase, reduces aqueous humor formation. So it decreases the production and lowers the IOP. So it can be both. I told you that these are the only group of drugs which are present orally and topically. So orally it is acetazolamide, midazolamide, ethoxyzolamide, and dichlorphenamide. But the most commonly used drug is acetazolamide. Topically it is dorzolamide, brinzolamide, and lodoxamide. The most commonly used is dorzolamide, and even we use brinzolamide. So what are the side effects with acetazolamide? So if given orally especially, there will be numbness and tingling of the extremities and perioral region. The patient will have numbness. The patient feels more weak if you give high dose of acetazolamide. So it will be metallic taste with acetazolamide, which is also called as, which is available outside as Dimox. Usually post-operatively we give patients Dimox. So Dimox or acetazolamide will have tingling sensation, numbness. That's the reason patients having more larger doses of Dimox, we ask the patient to take coconut water and banana because it will causes hyponatremia and hypokalemia. To compensate that, we ask the patient to take coconut water if he or she is not diabetic and banana. Okay, so symptoms complex will be there. There is decreased libido, depression, fatigue, malaise, and weight loss will be there. So gastrointestinal irritation will be there. Sometimes patients will vomit after taking Dimox. Metabolic acidosis will be there. I told you hypokalemia will be there. Along with that, hyponatremia also will be there. Renal calculi formation will be there in long-term usage. Blood dysplasias will be there, and dermatitis. So ocular side effects, transient myopia will be there. So these are all the systemic side effects and ocular side effects with carbonic anhydrase inhibitors. Okay, so topical dorzolamide, which is 2%, and brinzolamide, which is 1%. What is the efficacy? It reduces 15 to 20% of IOP, peak within 2 to 3 hours, washouts between 10 to 18 hours, Daily dosage depends, it will be 2 to 3 times. Usually we give 2 times only. Okay, so it is a BD dose. So ocular side effects, with other ocular side effects are induced myopia, keratitis, conjunctivitis. So contraindications, this is very important for timolol, it is bronchial asthma, but with contraindications with carbonic anhydrase inhibitors is we have to ask any hypersensitivity or allergic reaction to sulfonamides. If the patient is allergic to sulfonamide, we are not supposed to give carbonic anhydrase inhibitors. Now coming to the next group of systemic drugs, that is hyperosmotic agents, mannitol, urea, oral can be, which is IV always. Oral is glycerol or isosorbide. So how they act? They increase the blood osmolality. Osmotic gradient between blood and vitreous will be there. So water is drawn out of the vitreous. This is not action on the aqueous humor. This is the action on the vitreous. So the water which is present in the vitreous, it will take off the water from the vitreous. So what happens? The pressure in the, when there is volume of the vitreous decreases, the pressure in the eyeball decreases. So this is mannitol, injection form, 20% solution, 1 to 2 gram per kg body weight, over 20 minutes, not more than 20 minutes. You have to complete the bottle in 20 minutes. The action onset is within 15 to 30 minutes and peak action occurs at 30 to 60 minutes. Usually the action lasts for 6 hours. Okay. If the patient with lens induced glaucoma, there is high IOP and you want to do surgery immediately, we have to start the patient on mannitol. Okay, sometimes preoperatively we'll give mannitol, on table while doing surgery also we'll give mannitol to reduce the IOP. And post-operatively also, because we'll manipulate so much of iris, there will be iritis. To reduce IOP post-operatively also sometimes we need to give mannitol. So mannitol is given in IV form. So we have to complete the drip in 20 minutes and the action will occur within 15 to 30 minutes and the peak will be in 30 to 60 minutes. So before this 30 minutes ends up, we have to complete the surgery. Okay, that's the reason we keep it on table. We also give on table. So hyperosmotic agents, oral preparations, glycerol and isosorbide. The most commonly used is glycerol. We don't use isosorbide. It is glycerol. It is a 50% solution, 1 gram per kg body weight. Action onset will be within 20 minutes and peak will be 45 to 2 hours. So duration will be 4 to 5 hours. We should not give this in diabetic patients. So immediate post-operatively, if there is some vitreous loss or something like that, or you think if the patient will have raised IOP, immediately after surgery, before sending the patient out, we usually give glycerol. Okay, so this glycerol, if the patient is diabetic, we should not give glycerol. It is a contraindication. Okay. So side effects with osmotic agents are, hyperosmotic agents are gastrointestinal. That once we give glycerol, the patient or the patient will vomit sometimes in the theater itself. So you have to be very careful. The patient will have nausea, vomiting. Sometimes the patient will have anuria, potassium loss, diabetic ketoacidosis, urticaria, subdural hematoma, all these things. These are very rare. The most common thing is nausea and vomiting. So to summarize, beta blockers, they decrease the aqueous secretion. This is how, these are the various actions, mechanism of actions of various drugs. Beta blockers decrease aqueous secretion. Miotics, they increase the trabecular outflow. Adrenergic agonists decrease aqueous secretion. Prostaglandins increase trabecular and avoscleral flow. Carbonic anhydrase inhibitors, they reduce the aqueous secretions. So this is all about anti-glaucoma drugs. Do you have any doubt or shall I close the session?